Medicaid Oversight Advisory Board, the 6th meeting, and today is the 7th. And I would like to have DJ call the roll, please.
Senator Berg, Senator Carroll, Senator Meredith, Senator Richardson, Representative Heverin,
Here.
Representative Marzian, Representative Mosier,
Here.
Representative Williams, Vicki Yates Glisson, Holly Harris, Joe Petrie, Steve Shannon, Senator Douglas, Senator McDaniel, Representative Bowling, Representative Petrie,
Here.
William Baker,
Here for William Baker.
Laura Sudkamp,
Here.
John Hicks, Lisa Lee, Sheila Schuster,
Here.
Stephen Stack, Tom Stevens,
Here for Tom Stevens.
Co-Chair Rocky Adams, Chair Fleming.
Present. Thank you, DJ. Do I have a motion for the approval of the September 24th minutes? We have, nominated by, or forwarded by Senator Meredith, seconded by Senator Adams. Okay, very good. Oh, thank you. All in favor?
Aye.
All opposed by like sign? Okay, the minutes pass. Very good. All right, we've got a couple items up for discussion today. The first of all, we have the Certified Community Behavioral Health Centers. And if y'all would like to go ahead and make your way up to the table, I would appreciate it. We have some familiar faces.
What did you say?
It's under gender. The Certified Community Behavioral Health Centers. If you don't mind, just go ahead and introduce yourself. I will swear you in, and then I'll turn over the floor over to you all. Go ahead.
Good afternoon. Jennifer Willis from Pathways.
Danielle Amrine, North Key.
Elizabeth McCune, 7 County Services.
Dana Royce, New Vista.
Very good. And if you don't mind raising your right hand, repeat after me. I swear to tell the truth, whole truth, and nothing but the truth.
I swear to tell the truth, the whole truth, and nothing but the truth.
Thank you very much. I appreciate you commenting my little slip up there. My just is I do, but I went ahead for obliging me with that. So, in any event, anyway, go ahead and make your presentation. I think we have about 15 to 20 minutes. We'll do have some question and answers afterwards. So, you have the floor. Thank you very much.
Thank you. In an effort to keep us at our 15 minutes, I think we're all going to kind of stick to our scripts. So please don't understand that as disrespect. We're just trying to stay focused. So thank you for hearing from us today about CCBHCs. I feel like for content, we need to talk about community mental health centers and how that relates to certified community behavioral health clinics. So the CMHCs were established by statute in 1966 and have certain requirements that are outlined in your PowerPoints on page 3 and 4. We won't get into all those, but CMHCs are different than other providers because they are designed to cover the entire state. There are 14 regions that cover all 120 counties, and I'm sure you're familiar with your community mental health center in your region. Certified behavioral health clinics represent a fundamental transformation in how Kentucky delivers mental health and substance abuse services. Think of it as a CMHC 2.0, an enhanced model that integrates behavioral health, primary care, and wraparound services with evidence-based practices and robust quality measures. In 2014, the PAMA Act established the CCBHC model. In 2017, the CCBHC Medicaid demonstration was launched in 8 states. Kentucky had originally applied, but was not initially brought into the demonstration. But in 2020, with the addition of 2 states brought in due to the CARES Act, Kentucky was one of those 2 that were brought in to be part of the CCBHC demonstration. The Kentucky Go Live date for the CCB demonstration was January 1st of 2022, And in 2024, 10 additional states were brought into that demonstration. December 31st of 2027 is the date that CCBHC Medicaid demonstration with the enhanced match rate is scheduled to end. CCBHCs are required to see everyone who has any type of behavioral health need, regardless of age, ability to pay, or place of residence. CCBHCs are required to provide 9 essential services. Many of these services were already being provided by community mental health centers, but with the addition of 24-hour mobile crisis teams, outpatient screening, management, and referral, and specified services for veterans. There are currently 4 CMHCs in Kentucky that also operate CCBHCs. We're represented here with Pathways, New Vista, 7 counties, and North Key. These 4 CCBHCs make up 57% of Kentucky's population. I'm going to speak for just a moment about one of the special services that CCBHC provides, and that's care coordination. Care coordination is a required service for CCBHC, but is the driver in better health outcomes and individuals being served and supported. Care coordination is a practice where healthcare providers coordinate care with internal and external providers involved in a person's care. It really is a transformative service. The goal of care coordination is to provide care that best meets individuals' needs and preferences. It involves an ongoing partnership in the person's care where the client's preferences are communicated and facilitated through collaboration across various providers. We know that people with severe mental illness and substance use disorder die up to 25 years earlier than those without. Care coordination is designed to integrate all aspects of an individual's health care, physical, behavioral, and social, helping them live longer, healthier, and happier lives. Care coordinators play a central role respecting consumers' choice and ensuring collaboration across providers to meet comprehensive health needs. Some of the key roles to care coordination include scheduling and follow-up appointments for primary care, dental, or specialty care, providing health education and patient navigation, managing care and medications, referring to psychiatric or behavioral health services, including opioid use treatment, assisting with transportation, which we know is the #1 barrier for treatment in Kentucky, and connecting clients to community and social services. When someone is discharged from a hospital, an emergency department, or an inpatient behavioral health stay, this care coordinator follows up to make sure that all follow-up appointments are scheduled, ensures medications are continued correctly by the patient, but also makes sure that all providers in this patient's care are notified of those changes and have that documented so that they are familiar with how the patient will be medicated moving forward. These care coordinators provide discharge teaching and help with transportation needs to ensure follow-up to the next appointment. I would like to share a quick story about care coordination and how it's transformed just one of the many lives we've seen transformed by this care. We have a consumer with many chronic health issues, including morbid obesity, which makes ambulation very difficult for him. The consumer had stopped coming to his medication management appointments, and the care coordinator wanted to reach out to see what was wrong. This person also suffered from schizophrenia. Upon talking to him, she discovered that he was non-ambulatory and couldn't make it into his appointments. That care coordinator reached out to his primary care provider to see if there was any way that they could get home health in to take care of this patient. But because he hadn't been seen in such a long time, the primary care physician would not order that. So the care coordinator called one of our primary care providers, who was very agreeable to do a telehealth appointment. One of our nurses actually drove to the patient's house, did a physical assessment on him, took his vitals, and initiated that telehealth appointment with the primary care provider. We got him back on his primary care medications, set up pill trays for him so that he could for sure take medicines as directed, and then she also scheduled and initiated his telehealth appointment with his behavioral health provider. In addition to that, she scheduled him with a dietitian who worked with him on meal planning, dieting, and healthy eating. And I'm happy to report that after several months, he has been able to return back to the office. He's following his diet, he's taking his medications as prescribed, and he's doing significantly better. This is a patient that was clearly on the road to being in a nursing facility, a advanced nursing facility, who continues to live independently and is thriving in his own home. Thank you.
Co-chairs and members of the committee, thank you for the opportunity to speak today about the CCBHC transformation we're seeing and its importance and comprehensive crisis response. If anyone has watched the news lately, you know our country is in a state of crisis. In just the last month, my 2 teenage daughters have witnessed 2 different people lose their lives in very tragic ways. Their biggest concern going to school each morning isn't what they're wearing. It isn't if they're going to pass a test. It's literally how will they get out of their school if there's an active shooter. That's the world our kids are growing up in, one where crisis is no longer an exception, it's the environment. And when crisis becomes the environment, how we respond as a state really matters. Through the CCBHC model, Kentucky now has a true 24/7 crisis response system. Someone to call, someone to respond, and somewhere to go. CCBHCs fund mobile crisis teams that respond in person in real time, crisis stabilization units for adults and youth, and coordination with schools, hospitals, law enforcement to de-escalate emergencies and connect people to care instead of jails and ER. So what does a 24/7 crisis system mean for Kentuckians? It means someone to call. We operate the 988 Suicide and Crisis Hotline, ensuring that when someone is in a mental health emergency, there's a trained professional on the other end of that line 24/7. The people that call are someone's son, daughter, brother, sister, mother, father, aunt. These are real people, families in their worst moments. CCBHC funding ensures Kentucky has staff ready to respond in real time, saving lives and preventing costly ER visits. Someone to respond. Our mobile crisis teams respond immediately when a crisis emerges. Law enforcement, fire departments can call us for backup, and we respond to those calls, de-escalate, and prevent tragedies. This partnership protects officers, reduces strain on first responders, and keeps people out of jail who simply just need care. Somewhere to go. We've opened an adult and adolescent crisis stabilization unit, essentially a mental health urgent care for people in crisis. These units provide a safe, therapeutic alternative to ERs, inpatient units, and jail. 91% of the adults that we've seen in our CSU have avoided a higher cost level of care. That's lives stabilized, families together, and taxpayer dollars saved. For our adolescent unit, we complete school safety assessments immediately in real time, addressing concerns before they escalate and helping schools keep students safe. We can't change the fact that crisis has become part of our world, but we can decide how we respond to it. We have built a system here in Kentucky that works, a system that actually responds, but this progress is fragile. If we want Kentucky to be where help is always there when somebody reaches out, where our children can feel safe going to school, where our officers can serve without carrying the weight of every mental health emergency, where our neighbors can get the care instead of jail, then we must sustain this work. To walk away now will cost more than it saves in dollars and in lives.
So good afternoon. I appreciated hearing Allison Adams' testimony about accountable care organizations at your last meeting. Today, we're here to talk about how a similar model tailored for mental health providers, and it's being demonstrated in our 4 regions of Kentucky. Kentucky certified community behavioral health clinics are data-informed, using community assessments and performance metrics to identify gaps and deliver accountable care. They also provide population-focused services tailored for at-risk groups, including veterans who often face barriers to care. But what truly sets CCBHCs apart is their built-in collaborative power. As an example, in early 2024, more than 100 agencies united through the Community Health Needs Assessment to identify and prioritize behavioral health needs for Jefferson County. This collaboration continued long after the close of the assessment in May 2024 through ongoing bi-monthly meetings, where we refine strategies, reduce redundancies, and remove barriers to mental health care in our community. And we've already seen results. In the last year, our crisis call hub compliance increased by 53%, and mobile crisis outreach compliance improved by 68% to meet the 2025 National Guidelines for Behavioral Health Coordinated System of Crisis developed by the Federal Substance Abuse and Mental Health Services Agency, clear indicators of improved access and crisis response in our community. CCBHCs embrace continuous quality improvement, evolving services through outcome tracking and performance metrics. This is a dynamic, responsive model, one that fosters community engagement, strengthens crisis response, and builds a more resilient behavioral health system. In short, CCBHCs are not just delivering care, they're building a smarter, more connected, and more accountable system of care for all Kentuckians. Thank you.
CCBHC service rates are set by using a standard CCBHC cost report and prospective payment system, also known as PPS. Kentucky uses a daily PPS rate. The managed care organizations pay the contracted rate for individual service or services, which is essentially the CMHC rate. And then the MCO is responsible for submitting the encounter to Kentucky Medicaid to pay the balance up to the daily allowed PPS rate. The focus on cost reporting is that it's the cost to include all of the enhanced services so that we actually get paid what it costs us to deliver them. The Kentucky Medicaid CCBHC demonstration with the enhanced match rate ends on December 31st, 2027. In order to continue CBHC services in the next biennium, we estimate that $28 million will be needed to do that statewide. Further, a state plan amendment is needed and requested to continue beyond FY28. Enhanced CCBHC services are not only robust and outcome-driven, but they are also cost-effective compared to similar Medicaid provider types. As reported by Kentucky Medicaid for state fiscal year 2024, CCBHC services cost about the same as behavioral health multi-specialty group average per member annually, and approximately 60% less than the behavioral health service organization's average per member annually. Certified community behavioral health clinics are transforming mental health and substance use disorder services in Kentucky by expanding timely access to care, investing in the workforce, integrating behavioral health care with primary care, more availability of crisis services, including mobile, while also addressing social determinants of health. When basic needs are not being met, your physical and mental health care are not a priority. Ignoring your health care needs leads to utilizing services and higher levels of care that could have been prevented. CCBHCs have shown that they have been able to produce these results in Kentucky and will continue to do so with your support of funding needed in the next biennium and a state plan amendment to make it permanent. Thank you.
Very good. Thank you very much, ladies, for your testimony and your thoughts, and give us an understanding of and helping those who are least among us in order to get them in a better spot and so forth. I have a question in regards, I guess, in terms of providing services. Where does like the navigators or connectors integrate, or are they integrated into your operations, and how does that work?
I think you're referring to the care coordinators. Am I correct?
No, I'm talking about connectors.
Oh, connectors, okay.
Yeah, connectors and navigators.
Yeah, can I handle that one over here?
Yeah, go ahead.
They may partner with, they're not essentially at the present site. So they may make referrals to navigators to access, services if necessary, coverage if necessary, but they're not built into the CCBHC model.
Okay. Let me ask you this: given that you make a referral, and I assume there's no contractual basis between them and so forth, you just basically, that's part of what your responsibility, obligation, and that's wonderful, actually. Okay, I was just trying to get an understanding of that as well. Is there any questions or any comments from anybody? Representative Mosier, you have the floor.
Thank you, Mr. Chairman. Thank you so much for your presentation, and thank you so much for your work. I think this is critically important. It sounds like the demonstration project is doing what we thought it might do. And coordinating care especially for the behavioral health population is so critical. And we hear a lot about it. I think this is a perfect solution to all of the problems that we've talked about over the years, trying to integrate care. I mean, I'm working on a bill to bring the collaborative care model to primary care, which is really it's not as complete as what you're doing, but it's trying to expand the mental health reach into especially the more rural areas. So, what is your recommendation as far as how to grow this program? And I mean, obviously, we want to continue what you're doing and not let this great work go anywhere. Simply enhance it. But what would be your recommendation as far as how to grow this program?
Well, my recommendation personally would be that, and as we are doing, there are additional community mental health centers that are applying and doing the work to become certified as CCBHCs. I think the goal would be for all CMHCs to become CCBHCs, and then your state is covered from a regional standpoint. All counties would be included, and all of your Kentucky residents would be covered.
Okay. If I may follow up.
Yes, ma'am.
Thank you. So this would take the state plan amendment that you're discussing to allow the CMHCs to expand into this role.
Correct.
Okay. All right. Thank you.
Thank you, Representative. Senator Adams.
Thank you, Mr. Chairman. So, explain then what the relationship then looks like between you all and the MCO.
So the relationship stays the same. We bill our claims exactly the same way that we did before. But now once the MCO pays our claim, they submit the encounter to Kentucky Medicaid, who pays the RAP. So contractually, nothing has really changed with how we're paid through the MCO or the work. So all of the requirements are still the same. So with prior authorizations, all of those things we still do like we always did before. The only difference is that now we get the enhanced rate paid by Medicaid.
Commissioner Lee, you have the floor.
Thank you. I just have a question about the funding going forward. You said it was going to be $28 million. Is that for the current number of MHCs in the CCBHC pilot? And does it take into account the enhanced funding that the department gets right now from CMS in order to operate the pilot?
So in the estimate that of $28 million would be statewide, and it's really just taking what we estimate of the four of us would be required for half the year of 14 million, 28 total to take it statewide, because we represent about 57% of the population. So these are just estimates, and I'd be more than happy to get into the math with someone. Yeah. Really, that's two pieces. Part of it is the 20% roughly that Kentucky Medicaid is paying for just the enhanced cost. So that's one part of it, and then the other part is the enhanced FMAP that goes away at December 31st of 2027. So there's two parts to add up to that $28 million.
And then just for the record, if a state plan was created and submitted to CMS, we could not limit the CCBHCs just to CMHCs. We would have to open it up to any provider who qualified. And currently, I think there may be one behavioral health service organization that is in the pipeline to try to meet those qualifications to be a CCBHC.
Thank you. Representative Hebron, you have the floor.
Thank you. Thank you all for your presentation. It was very enlightening. Communicare is actually my are my people. And so I just wondered, for the last several years, I've been working on, or I've been part of conversations on 202A with the mental inquest warrants, specifically the transport. Is that still an issue for you all? And could you talk a little bit about that?
I can't see you, but I'm happy to address that. We actually arrange transportation for anyone who needs it, whether that's through our own transportation or through a Medicaid transportation provider, vouchers for transportation. So we currently provide transportation for anyone who needs transportation.
Including someone that's been served with the mental inquest warrant, because it's my understanding that the sheriff or law enforcement would have to.
Right, on a 202A warrant, that is correct. Yes, the law enforcement would have to transport for that.
Okay.
I was addressing just our regular appointments to and from the clinic or any primary care clinic.
Okay. Can I follow up with a comment? I think that would be something, just to continue the conversation for us. I know that's been an issue. And I think it's kind of a philosophical thing too of, I don't know that we, mental inquest warrants, if someone receives that, someone obviously needs mental help. And so, does the sheriff need to be involved with that? And I just know that's been a real issue for the last several years between the organizations and, kind of who's at liability, where do they need to go?
Mm-hmm.
And so I just think it's a really important continued conversation that we have in the General Assembly, whether that's Medicaid or not. I think it's something that really does involve you all. So I would just like to continue to be part of that conversation. Thank you.
One last question. Do y'all find any of your clients coming from out of state seeking your services?
Very few. We do live, Ashland is clearly right on the Ohio River, so we are very close to Ohio. We have a few folks that access our crisis care, but for the most part, they do not access many of our outpatient services.
Okay. Dr. Schuster?
Not a question, but I just want to add that we have been talking in Kentucky about integrating care for so long that it just it makes me tired. They mentioned the research that shows that people with severe mental illness die 25 years earlier than their peers who do not have a mental illness. Think about that, folks. And those of you who are on the physical health side know that these are not your most favorite patients. When they come in, and I have to say my daughter works in a clinic in Louisville, and she will call me sometimes and say, one of your folks are here, and they're scaring other people in the waiting room of the clinic. And that we have a hard time getting our people to go someplace because they get used to the community mental health center or the CCBHC. So I just have to emphasize with you all what's happening here in terms of really integrating. I think Jennifer's story about coordinating and the primary care doc said, well, he hasn't been in and that's the end of it kind of thing, and saying, no, this is somebody that has those needs. And he does also have schizophrenia, so the chances of his following through are about slim and none. And that's where that care coordination, it's more than just a case management. We hear about case management. This is real care coordination. And that, I think, is the magic to this whole thing. It really is getting everybody involved. And Liz's example of, 100 organizations have come together in Jefferson County, and it's because the CCBHC has called them together to say, let's do our planning and what's our priority. And it's I think a drop-in center for people, adults, and maybe then eventually for youth in crisis. So that's the kind of collaboration that you can do. And I think when you have that extra payment that allows you to do that, you can really do some innovative and transformative planning and action. So just a pitch. Thank you.
Thank you, Dr. Schuster. We do not have any more questions in the queue. We do have one of our...
Microphone.
Make sure your microphone's on, Vicki. Thank you.
Thank you very much for your presentation. It was very helpful. I have just sort of a practical question about understanding how the collaboration has gelled. Like, is it focused around the CMHCs? And so then if you were an AODE or a BHSO, you would contact the CMHC to become part of the team or the coordination entity. And how do you find your partners and so forth? So it was just really a practical question about how that coordination happens. So, and is there one specific entity that does this for an overarching entity?
So the experience in the 7 counties region was that we reached out to many of the community partners, police, fire, EMS, the mayor's office, some of the legislators, other providers, some of our advocacy groups, some of the representatives of different groups in the community that have historically had barriers to care. And just through word of mouth have added people to the group. Everyone is invited. Okay. The group wanted to continue to meet after the community health needs assessment was completed. So we meet every other month. We meet tomorrow morning at 10 o'clock at the Metro United Way in Louisville. And we will have a variety of people there. We continue to have around 75 or 80 people every other month that participate every time.
So 7 counties was really, the CMHC was kind of the driving force.
Yes,
in the Louisville area.
Right, we
And
set
is
up
that, have you found that across the state? I'm sorry.
Oh, go ahead.
I'll say that is the same. We have lots of MOUs with individuals. We do the same needs assessment for our area, and our experience is very similar.
So we continue to, we set up a website, we've set up email communications just to be the host, and we open it to anyone in the community.
And right now, is it just in the Louisville area primarily, or is it?
So we've invited people across the region, but it started initially with the health needs assessment piece that was for Jefferson County.
Okay. And the 28 million would allow you to now take that across the state?
Yes.
Okay, beyond the Louisville region. Okay, gotcha. Thank you.
Thank you.
Hold on, let me clarify.
Okay.
Collaboration is 7 counties, Louisville region. Jennifer Willis is in Ashland and Moorhead. Danny Amrine's in Northern Kentucky. Dana's in Central Kentucky. That's how we get to 57% of the population, and they're all distinct organizations, but those 4 are in the CCBHC, so it's just not Louisville that's driving the state. It's similar organizations throughout the state are making an application in certification to be a CCBHC, but those are the 4 pioneers.
Okay.
And it's from
that
Louisville
model
to Northern
seems to be
Kentucky
working,
to,
and
yes.
they're replicating that in these
Yeah.
regions.
Yeah.
Okay.
Okay, thank you. Thank you all very much, ladies. Next on the agenda is the non-emergency medical transport program. We have 2 individuals. We have Miss Pam Shepard and Adam Mather. So when y'all step up, when you sit down, make sure your mic is turned to green. The mic is close to you. And if you don't mind, go ahead and introduce yourselves, and I'll swear you in.
Sure. Adam Mather with the Kentucky Association of Healthcare Facilities.
My name is Pam Shepard. I'm with Federated Transportation. I'm the executive director.
Did you turn your mic on?
It's green.
Bright green. Hit it. There you go.
Okay, it wasn't green enough.
Perfect.
Okay,
There you go.
sorry. My name is Pam Shepard, and I'm the executive director of Federated Transportation.
Great. Do you don't mind putting your right hand? Do you swear to tell the truth, whole truth, and nothing but the truth? If
I
so,
do.
say I do.
I do.
I do.
Very good. Thank you very much. And you have the floor. Whoever wants to go first, whatever you want to do.
You're first on the agenda, so I'll let you go.
Kind of unsure. I received an email, and I appreciate you asking me to attend, and I will try to answer any questions that you have and kind of give you a small overview. I sent an email back asking, I wasn't sure what you really wanted, so I will try to help you as much as I can. I've been a transportation Medicaid broker for the NEMT program. We started some pilot projects in 1998, and we became a broker in 1999 for Region 10, which was Lexington. And over the years, we've acquired 3 other regions. Acquiring is that there was an RFP out there for a proposal, and it went through the finance cabinet, and each region was bid on. So that's how I acquired the other regions over the years. Okay. So we have Region 6, which is Louisville, Oldham, Bullitt, Shelby, Spencer. I don't leave anybody out. Henry, Trimble. Okay. And then we have Region 9, which is the Northern Kentucky area, Boone, Kenton, and Campbell, and Pendleton, Gallatin, Owen, and Carroll. Okay. And then Region 10 is Lexington, and Region 11 is Bourbon, Harrison, Nicholas, Clark, Montgomery, Powell, Estill, and Clark. So those are the areas that we serve in our area. Now, the state of Kentucky is broken into 15 different regions. So the whole state's broken down. So there's Medicaid transportation services that's given all the way across the state. Everyone has the same regulations that they have that is given to us from Medicaid through the transportation cabinet to us. We do not set rates. We do not set the rates to the subcontractors. We do not set the rates that we receive. Everything is given to us. And so as a broker, we are an at-risk program, so we take all the risk. You know, if it's good, it's good. If it's bad, it's bad. But we take the risk as a broker. We each one of the areas that serves in the different regions that we have in the state for different areas has a central scheduling office available, and in that area, you would call in to the your 1-800 number that's given in your area and to schedule transportation. So at that time, we would determine, we would check to see about your eligibility, but we do not determine it. We just have access to a Medicaid screen, and if there's any issues, then we have to send that to the transportation cabinet for approval or disapproval for that individual to ride. But the only people that are eligible to ride would be an individual that is eligible for Medicaid and is attending a Medicaid eligible facility or activity that they need to go to. So all this is in the statutes and the KRS that's provided to us to do. So the person would call in, they would give us their information, we put it into our system. That would be, you know where you need to go, the timing, if it needs to be a subscription trip, if you would need to go 5 days a week, 4 days a week, or you just need a one-time doctor's appointment, we can put that in. Because if someone's scheduling a subscription trip, we only require that person to do it one time, and the only time you need to call back is if you need to make changes to it. So it's not making it a hardship on the individual to do that, so that they can just change the times. They can, those are going to any type of facilities, from adult day facilities to support for community living, brain injuries, or Miss Jones just going to see her doctor, or if you go to dialysis appointments or anything like that, anything that's a Medicaid covered service. And they have to be within range of contiguous counties. So there's a lot of rules and regulations, but all that was all put together and added on to since 1999. And we have to follow all those rules and regulations. We currently have about 89 subcontractors that work under us, which encompasses about 1,000 drivers, like 900 vehicles through all our areas that we have. So it can serve any of the individuals that would need service in our areas. So we have scheduling is from 8 to 4:30. Monday through Friday, 8 to 1 on Saturdays, but we have a 24-hour urgent care line that we have that's given, that if someone needed urgent care, they can do that and call in. But a lot of things is like predetermined. We have to do it according to what the regulations are. I'm not sure, like I said, there was questions about scheduling that you wanted to know. I'm not sure what else you'd like to know.
Well, I'll tell you what, let's have Mr. Mather, if you're finished, let's have Mr. Mather talk and make a presentation, if that's okay with you.
Yeah, that's fine, it's fine.
Okay,
No
and then
problem.
we can come back and we can sort of, ask both of you. That's okay.
Sure.
Go ahead, Mr. Mather.
Absolutely. Thank you all for having me. I truly appreciate the opportunity. So, like I said, I represent the long-term care facilities. I would say we serve about 70+% of the individuals are on Medicaid, and so they utilize the non-emergency wheelchair transport. Some examples of those appointments include dialysis, preventative medicine, diagnostic test appointments, follow-up from procedures, new procedures. And just to give you an idea of what that looks like when you're scheduling that, I'll go through the kind of process if that's helpful. So to schedule a wheelchair transport, the facility, typically it's the social worker, will make an appointment for the individual, and they need to make that appointment with the transportation broker who has a operator system 72 hours in advance of the appointment. The broker then assigns that individual appointment with a confirmation number and dispatches the trip to a subcontracted transportation provider. The transportation provider on the day of the assigned appointment then picks up the resident and takes them to the appointment. Once the appointment is finished, the medical appointment or the provider office has to call the broker, and then the broker request a return trip from the subcontractor, and the subcontractor then will pick up the individual, and the resident is then brought back to the facility. And then, so just the issues that we've had, and I want to go through some of the challenges and barriers that the facilities have seen so that you guys can understand in totality some of the concerns that we have. So the first one is limited responsiveness. This is a very common practice. I was a long-term care administrator 10 plus for over 2 decades and haven't done it in about 8 years, but it was a consistent problem when I was a administrator. But there's limited responsiveness. Subcontracted drivers often arrive in the parking lot without entering the building. They, I think by statute or regulation, are required to stay there for 5 minutes and wait for the individual. They'll wait in the parking lot unannounced, and then they'll take off. So no one knows they're there, and then they leave. They will consider that, they'll mark that as a no-show. So the individual doesn't know. I can personally tell you of a time when I took an individual to the restroom. We let them know that we were taking them to the restroom. They waited the 5 minutes and then left. Delays in the return trip. After appointments, residents may wait 3 to 6 hours, and that's not an exaggeration. We've had dialysis clinics that have closed and waited 3 hours after closure to be picked up, sometimes even very late into the evening for return pickups because, it requires the facility to get multiple calls between the office, the broker, and the subcontractor. Unreliable scheduling. Confirmation numbers don't guarantee on-time services. Trips are frequently rescheduled or canceled without notification to the facility, and that happens last minute. After-hour issues. Hospital discharges often occur in the middle of the night because the transportation is unavailable earlier in the day, and that delays access to appropriate care settings. And limited escalation options. Facilities really have no direct control over subcontractors. It's kind of a finger-pointing situation. When you call the operator, they blame it on the subcontractor, which you have no direct contact with, so there's no real accountability at the end of the day. And then I can tell you, I would love to see the data, and I think it would be helpful for you all to make some assertions, but on same-day cancellations and unfulfilled trips, commonly known as no-shows, because they're a very common occurrence. The impact to residents and facilities, I can assure you, residents missing or delay essential medical appointments can cause and often does additional exacerbations to their issues, certainly with dialysis. Those appointments are scheduled very tightly, and so often they'll have to go to the hospital for emergency dialysis, which is extremely costly. Not only that, it's very difficult on the individual to have to take that on, especially if they miss a dialysis appointment and you're getting them in later. And then if there is an issue post-procedure and it's not immediate, it's really hard to schedule those follow-up visits again if they've missed that first one. We've seen so many issues with some of the, like orthopedics, for example, that they require the facilities to, they blame the facilities, unfortunately, and they require the facilities to send a staff member with the individual because they feel like it's the facility's fault. And so, obviously, we've mentioned many times that staffing is a premium and obviously an issue. And so to take a staff member away from direct patient care to have to go there and sit in the lobby while they're doing a follow-up appointment is obviously burdensome to not only the facility, but obviously the direct care that needs to be taken for the patients in the facility. And then most recently, I think in an effort to try and curb some of this, facilities have been providing at their own liability transport on their own and not being reimbursed for that. So that's a huge expense, more so on the liability concerns than just the reimbursement cost. So I just really wanted to kind of cover some of the overall kind of concerns, the barriers, and really the process by which the facilities are being provided the service and the residents.
Thank you. I appreciate both of y'all's comments and give us a perspective on both sides of the issue in terms of providing Medicaid recipients. Mr. Shepherd, I want to ask you just a couple of questions. So let me make sure. So you're like 15, 16 regions. The state pays a per capita rate in terms of providing those services. You said you have 89 contractors. It's probably not unusual for the other brokers to have that number as well. So it's a lot to manage and take care of and so forth. And y'all have a set, do y'all explain the relationship between you and the subcontractors in terms of the contract goes? Do you have a negotiated rate or what?
No, the rate that's set for the subcontractor is a rate that's given to us from the transportation cabinet, which is who we get it from. But then that's set up with Medicaid.
Okay, so that rate is an actuarial basis. Based on historical information, and each region is going to be different given the dynamics and the topography and the lift and all that stuff. Okay. I wanted to ask you, do you know what your utilization rate is?
I can throw you some. Okay, here's I know that you want to talk about unduplicated. Okay, so an unduplicated, like in my 4 areas, I had like 8,500 unduplicated. Now, I understand that this was a month I just pulled. So, if you had so there was like 527,000 eligible people, but only 8,500 used it. But out of those 8,500 people that were unduplicated that used it, there was 136,000 trips that were performed. So what it comes to is that an individual that uses a service is a small percentage of the total amount of eligibles, but that one individual can go 22 times a month, or more, and then it turns out to be that those trips can go up anywhere to $60,000 a month, a year for that individual to use the service. So it's not uncommon, because I have many people, because I was looking at some numbers that like their $258 is their total round trip for a day, and you take that times 22 times 12, and so that's what happens but that small portion that's using it is utilizing a great deal, and that's what happens.
Okay, and I appreciate that explanation. The report that I received from transportation through DMS that your utilization rate is 1%, and that's not unusual for the other regions as well. And I'm looking at the sheet right here. Transportation, I guess DMS came out with 24%, but this chart is not calculated correctly. But basically, it's about a 1 to 2% overall utilization when it comes to this particular service. I understand and appreciate the number of people might be small and their volume that they might use it, go 2-3 times a week. I understand that, but things somewhat relate anyway, no matter it's the number of times they use it or individuals, because the utilization is pretty small. So that's, to me, it's quite alarming. And I can't get a very good comfort level. And maybe the DMS or the cabinet can explain that a little better for me. But when you're looking at 1 or 2%, it's quite alarming. So you got a question like $175 million each year that basically goes to this particular program, and this is all federal money. And then the state basically contracts with transportation to about $1.5 million over a two-year budget in order to manage and all that and so forth. So do you have any? I guess you have any comments or thoughts about what I'm missing here between what the report that I'm getting from Transportation and DMS and you all and what you're telling me?
I mean, I'm not sure about the numbers that you have. I'm not calculating those in here. The only thing is if an individual calls in, we set them up transportation, and it comes to be where the people that call are the people that are set up for transportation, and the money we receive is set for us. So I can't control any of that on that part of it. So, when you're balancing the utilization and the numbers, those were set for us, and we're not setting them.
And I know you're not setting them, and I appreciate that. And that comes, like I said, it comes on an actuarial basis and so forth, and then basically pay you. But is there any leftover money, or is anything that y'all receive on a per capita basis, for your old region, and then they're actually not using that money?
We have an MLR that is set up for us, and that means the amount of money that's paid out to the subcontractors and the amount of money that's given to us. Okay, so FY25, my utilization was 88%. So that left
utilization or MLR?
No, I'm sorry, my MLR. I apologize. My MLR was 88%. So that left me 12% to run my agency. And then in FY24, it was 94% the MLR was for my 4 regions. So that left me 6% to run the system.
So you're telling me that you're utilizing your portion of the money that's allocated in total. There's no money left over other than basically paying for your overhead costs.
That's the program was set up at an 85-15. Yeah,
right. I'm asking you the question.
No, the leftover money is for me to run my agency.
Okay.
Right, and to pay for my call center, pay for the building, pay for the insurance, pay for that.
Okay.
The leftover money is.
And I'm not. I understand what you're saying. I just got a disconnect, and
Okay.
we need, and that's nothing on you, because the report that I'm getting to what you're telling me and what I'm seeing with each region, it's 1% to 2%, and you're saying you're being, you maximize your money on this, and your MLR, is 88%. On average, everybody's like 91. There are some at 84. So that sort of gives me a little bit of concern. So I'm trying to reconcile this from a financial standpoint in order to, make sure that the money is being used properly, because we are stewards of taxpayers' money, knowing if the federal money is being used or state money is being used. So, okay, there's any other
No,
thoughts
I mean
about
that. Like I said, I can't control either parts of that. That part of it. I mean, like in the month of July, it was 98% in Region 6. My MLR was 86 in Region 9, 91 in 10, and I think it was 85 in Region 11. So, no, 89 in Region 11. So, but those were my my numbers from July of my MLR.
Okay. All right. Senator Berg, I'm sorry.
This one.
Senator Berg, you have the floor.
Yes, sure. Thank you. First of all, my first question: what does MLR stand for? Medical loss ratio. Okay.
Basically, it's a measurement whereby it makes sure that the higher the number, the better the money is going toward communications and providing services to that Medicaid recipient. The lower the number means they're not being as efficient and they're keeping more of the money or doing whatever with it. Does that help out?
All right, thank you.
Yes,
You.
ma'am.
I've a question that may arise from an entirely different incident, but I had multiple complaints of transportation services in my district for people with disabilities, doing such a poor job in arrivals on time and meeting people and taking care of people and transporting people that honestly disabled people have lost their jobs because they just are not getting to work on time. These transportation services are just not working for them. And I'm wondering, with such a low utilization, rate. What quality measures do you use to make sure that your subcontractors are providing a timely service?
We receive the information back from us. Now, I have put in a brand new software, which actually is going to give me better access to my subcontractors, meaning that if someone like I could pinpoint the particular driver on like you had someone writing, and you gave me a name. So you gave me a name, and then I pulled that person's name up, and then I could find out what company was taking them, what vehicle they were in, and I could tell you exactly where the vehicle was. So this is something that's being put in. We're only a month into it now, but this was something I felt like that really needed to be done so that I could really keep an eye on it. So I wouldn't be completely in the dark when someone calls and says, "Where's my ride?" And I would be at it. I'd have to listen to what the subcontractor told me, because if I called the subcontractor, they could say, "I'm on 5th Street," and actually they're way out in the country. But this way, because they're going to have an app on their phones or their tablets or whatever in their buses, it's connected back to my system, then I would be able to know exactly where that person is. So I felt like that those types of measures, then I could keep up with them and knowing exactly what I was doing. So that was one thing that I put in place now.
Follow up, sir. So historically, your quality measures,
Okay.
do you, what percentage of times people are picked up in a timely manner, how long people have to wait for a response? You don't keep track of any of that type of data?
The data goes into, we have a report that goes into the transportation cabinet to Medicaid, and it's going to show when a person's picked up and when they're dropped off. So we get that back from every subcontractor so we can go over it and tell now giving you a total percentage of how many people were late or not, but if I could sit down and do that to see if people were late. But we do get timing. But like I said, I would be at what they're telling me. This way, with this new system I'm doing, is when they hit arrive and perform, I'm going to know. So historically, I didn't have as good account on it. Going forward, I will.
Interesting. Do you think there's any possibility that the low utilization relates to the fact that people perceive a poor service?
And I can't really say that. I think that it's just because there are stipulations upon when a person is eligible. I mean, there are eligibility questions. There are that if you have your own vehicle and you can drive it yourself, then you're not eligible for the service. So there's reasons that people wouldn't be eligible for it. And then, of course, there's people that don't even call. So, I mean, but those are the people that, we don't know about. But I'm not going to say, I can't really say to that question.
Thank you.
Thank you, Senator Byrd. Senator Carroll, you have the floor.
Thank you, Mr. Chairman. And these questions are coming from a subcontractor and then also a provider of adult day health services. And my experience is not from your region; it'd be from the Grits region, down in Region 1. What expenses are there that you all can control related to your subcontractors?
What expenses I can control?
Yes. Are there what fees and what revenue comes to you from your subcontractors?
I'm not receiving revenue from the subcontractors.
I'm talking about things like drug screening and those types of things that are required.
Oh, I'm sorry. Okay.
Yes.
So the subcontractor is required to perform drug testing. They would do a pre-employment drug screen whenever a driver is or a person's in a safety sensitive position. They have to do a pre-employment drug screen. Then they would be put into a random drug pool. And then whenever their name was drawn or they were in an accident that deemed a drug test, they would have to do that.
Who sets the cost for those?
That is gone through a consortium through the transportation cabinet that we use for even from the public side. And we have gone out to bid, and we have a consortium with an MRO that we've contracted with.
Okay. Do you all get any cut from that, or is it is there any profit from that?
No. All that money, whatever the cost is that you as a subcontractor would pay, goes directly to that. I don't receive any percentage of it.
Okay. And Mr. Chairman, if I may,
Go ahead, Senator.
the reimbursement rates would often fluctuate throughout a period of time, and I know those are set by the Transportation Cabinet. And when that changes, how do you all determine what your rate will be to subcontractors?
I don't determine it.
So all of that is set.
Nothing is determined. I do not determine the rate that I receive, nor do I determine the rate that I give to a subcontractor.
Okay. And as a service provider, one of the biggest struggles that I had before I retired was the transportation provider picking our individuals up on their time frame and not what's convenient or what the participant in our program requests. And for providers, it's usually a very limited profit margin, and the time that individuals spend at the center is important to the bottom line of many organizations. Yet the transportation providers are, particularly in our region, I don't want to say you do this or any of your subcontractors, but they would pick up what was convenient for them, and they set the times regardless of what the center requested or what the participant requested. How does that work in your particular organization?
We ask for a time that they need to be there, and then that can be adjusted upon where they live. But transportation is set up as a coordinated service where you're picking up other individuals. So if you're picking up 2 or 3 people going to the same place and one lives out here further, that one be picked up first. But I let that be set up with the subcontractor to they're setting up their times that they're doing it.
Okay, so the individual coming from a center, they do not have the ultimate say on what time they're picked up?
They can. You can request a pickup time. I'm not saying that you can't request a pickup time.
But they ignore it. Okay. And then they were also deciding basically when we would close our program down if bad weather was expected. They were making that decision for our organization. So not really a good relationship with grits in our part of the state. It really felt like our participants in our program were not in control of their transportation at all, and a lot of fluctuations as a subcontractor with the prices, and a lot of issues with the state on whether or not that family had a workable vehicle where they could get the funding. And I think that's kind of leveled out, if I'm not mistaken. But, Mr. Chairman, those are issues that I've experienced over recent years that thought I would share a little bit.
Thank you, Senator. I appreciate your comments. Commissioner Lee, you have the floor.
Thank you. I just wanted to thank you, Representative Fleming, for bringing up that 1% utilization rate. I would like to go back and double check that report and look and see that if it's monthly, it would be a little bit lower, but that is, I'm very thankful you raised that concern. I did want to address the Medicaid's portion of, I think we asked about a quality piece. Medicaid does go in and check on a routine basis to make sure that a non-emergency medical transportation trip occurred on the same day as a medical service so that we can align those two. So I just wanted to make that known that we do have quality checks on it. And the last report that I looked at for the non-emergency medical transportation program had over 2 million trips delivered in 1 year. So that's a significant number of trips. So as you said, a low number of utilization in our members, but definitely a significant portion of trips being delivered.
Thank you, and I appreciate it, and I appreciate if you would go back and check those numbers out. That'll be most helpful. Let's see, Representative Mosher.
Thank you, Mr. Chairman. Thank you for being here and helping us understand this program, because it's a relatively new conversation that we're all having, I think, and we're just trying to wrap our heads around it. So I hope that you're not taking any of this as an attack on your work. I do appreciate that you're here.
Thank you.
But I do have a couple of questions just for my own clarification. So how are the transportation providers contracted?
any able and willing individual that would like to become a provider could contact us or any of the brokers that are in the area, and then we would go through a series of things. So we have to make sure that the company is reliable, is legit, is, can background checks that we ask on ownership. We want to make sure of that before that. They have to have operating authority already before they ever get to us. To our part of it, you have to have operating authority through motor carriers. Or if you're a nonprofit, you'd have it through the Office of Transportation Delivery. Once that part of it is gone through, then the individual there's a MAP 811, which is a Medicaid questions that are asked for a person to get Medicaid numbers. And so then our organization or the brokers will sign off on the MAP 811. The individual then they would submit all that back. Okay, so then that's a process. Everything's a process, and it takes a while. And I let people know that it isn't fast. It's not a fast process. The process it goes through. Okay, so once that goes to Medicaid to get their Medicaid numbers, and that comes back. So then we go through and we have to check out your vehicles. We do an inspection on all the vehicles. We have to get information about each driver that you're going to have. So each driver will have to have a pre-employment drug test. They will have to have passenger assistance, a certification that they've attended that. They would have defensive driving. They have these certifications that they would send us that they've completed, different types of trainings. And then we take all that packet together, all the information. We have to make sure that the subcontractor has insurance on their vehicles, workers' comp on their employees. All their employees have current driver's licenses. So all that information is put together and put into a packet, and that is submitted to the transportation cabinet. Then the transportation cabinet would take that packet and then tell us that person's ready to go. So when then they would approve them to be a provider. Then I would get a contract, and our contract, and would send back to them, and then that would be with the rate sheet that is provided from the transportation cabinet, which we would pay them. And then we'll bring that person in, and we'll give that person an orientation about how our system works, and talk about the billing process, and how in everything, like I said, with our new system, it's going to be about getting an app and putting it on their vehicles. And we've had that set up with a 2-point authentication, so everything is going to be good. They all have to sign confidentiality statements to make sure that, because they're getting a lot of confidential information that the subcontractors are. Also, one thing that's very important is that we do a criminal background check that's completed. Now, all of these things that the driver does is on a criminal background checks are yearly. The pre-employment drug screen is just one time, and then you're in a random pool for drug and alcohol. The passenger assistance every 2 years. So all of these things, and then we keep all that information in a file that we have in our office. So when anything becomes expired, when we get back or getting close, we have like a tickler that whenever it comes back to when it's going to be time for that to expire, then we let the subcontractor know so they can make sure they get all this updated. That's the same thing with their insurance and their workers' comp and everything else, because we want to make sure that we're the gatekeeper. We're totally responsible for what's happening. So we want to make sure that the subcontractor and the drivers that we're giving it to is passing all of this information. So then that person, then we would, like I said, after they come in for their orientation and we set them up and tell them about the billing, then we would start, they would be in our system to be a viable provider. We let our individuals choose the providers that they want. If they don't know who they want, then we would try to put them out, because I have many providers, like in Jefferson County, like 60. So it's kind of like there's not a whole lot left over for people that especially want to be new providers. But so that's kind of the process to become a provider.
Okay, thank you. That was a really thorough answer. I really appreciate that. I mean, because you ended up answering a lot of the questions I had. And so I feel like I'm going to jump around a little bit, if I may just ask a couple more questions. Okay, so we talked about some of the no-shows and some of the patients not receiving the transportation that they thought they were getting, they were waiting for. Are these drivers paid no matter what?
No, A no-show or a cancel is not paid. So it's really to the driver and the company's disadvantage not to pick up someone because they're not paid for no-shows and cancels. So it wouldn't behoove them to do it deliberately because there's no payback to them to just automatically say that. And that's the other thing is, like I said, with my new app that's coming up, is that it will let me know that if they're actually in close proximity to that. And if they try to cancel or no-show it, it never went, I'll know.
Okay. And so, last question, I promise, but it might be a multi-part. All right. So this is a $175 million a year program, and the patients are Medicaid eligible patients, and there's a capitated rate. I mean, it's set per capita. I'm trying to understand how, as a region, there are 15 regions. That would be 11.6 million per region. Your MLR is 81%, so that means your administrative costs are about $1.4 million a year. Does that sound right?
I mean, it wouldn't be divided up per region because each region is not the same size, and so not every region. So I mean, that's because there's difference. Yeah, it's per capita. Like the per capita rate is set per region. Okay. So
gotcha.
That because each one of my regions, I get a different amount of money. Like people are only like $7.82 is what a person like is worth.
Oh, so that would be like the general cost of a ride.
Like the cost per person is $7.82, but then you have one person that's, and like I said, the utilization is low, but for someone that
for
uses
the number of patients, for the utilization for that patient is high.
For them to use it, 30 times a month. So you're talking about in some places it can be over $60,000, and I know that. Speaking to one of my colleagues, she had one trip that for the year was $124,000.
Wow.
Okay. So, but it varies. It's just that's a hard one to pinpoint. But the numbers vary.
Okay. All right. Thank you.
Thank you, Representative. Quick question. You mentioned about the driver only waits for 5 minutes. Was that who says that, or is that a policy?
No. If a person went to a house and like somebody came out, that was just that they couldn't hit their button in less than 5 minutes. They couldn't just they have to show. I'm talking about on my app, they couldn't hit a button. You've got to actually go and sit there. You've got to wait on a person. And the app wouldn't let you. You could leave, but you can't cancel it. Is what I was saying. They can't just cancel it.
Okay,
They've got to be there.
I just want to clarify. There's no policies.
No. I was just talking. I was just talking about hitting a button. It was just a button.
Senator Adams,
I'm sorry.
Well, I was going to ask Pam a question, but Adam is just sitting there minding his own business. So maybe I'll ask Adam a question. Okay, I understand. And rightly so, you all have been frustrated. I hear the same stories you do about transportation, and there is a real frustration around it. Have you all ever thought about maybe becoming a subcontractor and participating in the program?
So there are some individuals that do participate in our subcontractors, but there is also the implication that they would have to subcontract out for, they may be a preferred provider for somebody out in the community, and they don't have the staff
rather than just your own entity.
Right, just your own entity. Correct.
Okay, that makes sense.
Yeah, it would be difficult for them to do.
Yeah, thank you, Mr. Chairman.
You're welcome. Ms. Shepherd, this probably the last question, and we need to move on. So what would be your thoughts on terms of, I think you mentioned about trying to find some savings in the budget. I thought you might have mentioned that. Did you mention something about that? Okay. No?
I don't-
Okay.
I'm
I
not
just
sure-
wanna-
I'm not sure.
All right, maybe I misinterpreted that, but I just
Yeah.
want to, because I thought you said that you might have some ideas or thoughts that pertains to some budget savings or what you can do and so forth. So that's where I thought you were going at one particular point in your conversation.
Well, I mean, when it comes to it, is we are a transportation company only. That's all we do. So anything that we have is invested back into my employees and my operation. It's not taking care of other entities. So, if, like I said, even with the numbers smaller, we've been able to survive. So, that part of, I mean, from a cost savings, I mean, we've still been able to continue, even when the margin has been less.
What's your total contracts with the state? What's your total contract worth? And then, which includes your subcontractors?
The amount of money that I receive,
Yes, ma'am.
$40 million.
$40 million for all 4 regions. And that includes subcontractors?
That's
Okay.
that's the capitated rate.
Okay, and what do you show? You're a nonprofit, right?
Mm-hmm.
Where's that show up in your 990s? Do you know? Okay. I appreciate if you could just let me know where that shows up, because I had a hard time trying to find where that showed up. Being familiar with 990s, you try to put as much as you can in there for disclosure purposes. But okay, well, thank you very much. I appreciate your time and your testimony. Okay, how many? 4, 12 minutes. Okay. Where's my agenda? All right. Okay, we have 2 more topics. We have the administrative regulations and then the public comment. In your packet, I believe there are 5, regulations. I believe the first one in the packet needs to be, put aside. Don't pay attention to that. But the other 4 you need to pay attention to. And I'm going to ask Chris, staff, if he could read those regulations.
The regulations under discussion today are 907 KAR 008020, Independent Physical Therapy Services Coverage Provisions and Requirements, 907 KAR 008040, Coverage for Occupational Therapy, Physical Therapy, and Speech Language Pathology Services, 907 KAR 010016, Coverage Provisions and Requirements Regarding Inpatient Psychiatric Hospital Services, and 907 KAR 023010, Outpatient Pharmacy Program.
Very good. I appreciate reading those out. Chris, is there anybody who has any comments about this? Okay. Very good. Senator Adams.
Yeah, I didn't know if we had anybody from the administration that wanted to comment before we get started. Sure, Dr. Stack.
I think these are an open comment period, so I don't think we can comment on these right now. So others can comment all you want, but I think we have to be quiet because this is in public comment right now. So we're in the business of receiving comments, I think, from you and the others.
I appreciate that, Dr. Stack. I would respectfully disagree with you on the public comment period, that you cannot participate in commenting on these. Well, first of all, House Bill 695 requires that if there's any change in coverage or change in cost, that it needs to be brought to the General Assembly for conversation. And last session of the General Assembly, we passed Senate Bill 23, which was basically the statutory basis for any legislative committee of the General Assembly to hold hearings on any administrative regulation once it is filed by the LRC. And the governor actually signed that into law. And so I think that regardless of whether we are in a public comment period or not, it is our job, and it's in statute, that we talk about any any administrative regs that will result in a change in coverage or a change in costs. And so I think that if we look at the 4 regs that are before us today, they do those things. They have a change in coverage and a change in costs. And I actually have a couple of questions on those. In particular, I mean, if we look at the last one, 907 KAR, I mean, that one, does this regulation expand the coverage of outpatient drugs to now cover drugs for anorexia, weight loss, or weight gain? I mean, are we covering GLP-1s for weight loss right now? I mean, are we doing that currently?
So on this one, I don't desire us to be in conflict in this. I just want to be clear. We weren't told specifically what we wanted to discuss for this, so I don't think we've really been given the opportunity to come properly prepared. If we want to discuss 695 or the other pieces of legislation, because it is our intention to comply with 695. So if there's a belief that we have not, I think we'd like to know where that has arisen so we can have a discussion on that. So I don't think we're intending to not comply with 695. On the broader issue related to the regulation filing process, and again, you've referenced a specific bill, and forgive me if I want to make sure we have the right bill numbers that I'm referencing. I think there's currently a difference of opinion on that between the executive and the legislative branch, and that's one of those bills may be in litigation at the moment. So on these things, I think we can have a discussion. I just need to know more clearly so that we can come properly prepared in advance and with the right people. As far as the regs that are actually currently filed, and again, we'd probably bring counsel so we can make sure we answer these questions clearly and appropriately. In general, when a reg is open for comment, the executive branch is in a stance of receiving input from others, not commenting on the reg itself. So that's a quiet period typically. That's been my experience when I petitioned the federal government for 2 decades as an advocate, how they treated us when I went and spoke with them. And that's generally how I have seen it done here in my experience in the executive branch. So again, we're not desiring to deprive the legislature in this regard the opportunity for comment. It's just that when we're in an open comment period with the public, that's usually a quiet phase for the executive branch. And again, we'll be happy to discuss these if you tee up the issues, and we can come back prepared for a future hearing and have that dialogue.
Yeah.
Or meet offline and have a discussion just to make sure we're understanding each other's questions and concerns.
Sure. And we can kind of debate the public comment period, back and forth. But if you look at the statute, House Bill 695, Section 1, and I'll go ahead and read it to you. It says, notwithstanding any provision of law to the contrary, including but not limited to KRS 205-460 and 205-520, the Cabinet shall not, unless required by federal law, exercise the state's option to develop a basic health program as permitted under 42 U.S.C. Section 18051 to make any change to eligibility, coverage, or benefits in the Medicaid program, including by pursuing or applying for a waiver of federal Medicaid law under Title 42 of the U.S. Code, seeking to amend or renew an existing waiver granted under Title 42 of the U.S. Code, or pursuing the state plan amendment without first obtaining specific authorization from the General Assembly to do so. So I guess my point is that we would have preferred you follow statute and come before the General Assembly to discuss this. And so, I, for one, would have been open to having the conversation about these things as statute holds, without first obtaining specific authorization from the General Assembly to do so. I just would like to follow what the law is. Because, I don't know why we have to make things hard. I just would rather have a collaborative relationship.
Go ahead, Dr. Stack.
And again, I share that feeling. And again, this is where I think it would be helpful to have the specifics, because lower in that same statute, it says any act of the General Assembly directing CHFS to make changes brings with it the authorization to make the changes. And anything that says that we have to comply with the federal government, with CMS requirements or federal laws, are things that we are allowed to do and give notice to the LRC, which I believe we do, because when we file regs, we've notified the LRC and filed those regs. It goes before the RS committee, it goes before the committee of jurisdiction, and now MOAB is an additional, convening of the legislature and others. And so, again, there's carve-outs in here for specific circumstances for us to be able to actually operate the program. And so this is where the details matter greatly. So I don't really yet even now feel that we're in conflict until we have the specifics, so that we can understand that clearly, and then we can discuss. And once we've discussed the specifics, if we are in fact in conflict, it'll be very clear. But right now, I just think we needed more of this detail in advance so that we could have known what we were coming here today to discuss.
And I appreciate that, Dr. Stack. Part of the thought is that when you file these regulations, it comes with LRC, and then you go into public comment. Once you filed it, you could have contacted, the chairs. You could have contact LRC in general that they have filed it, and you filed it, but there's no communication. We didn't know exactly what's going on, and all of a sudden we see this. That's our point. We just want to have a stronger communication, and I think you and my co-chair now, we met, and as well as commissioner, we met to talk about having good, strong communications, because we want to try to do a very collaborative, cooperative approach, because we're all here to help out those least among us, and that's what we want to try to do. So we want to make sure that procedurally we go through the process and make sure that things are adhered to. Representative Bowling, did you have a question?
Just a question for Dr. Stack. So are these regs, is it your opinion today, I guess, that these regs are only to comply with federal mandates and federal law?
Okay, so Representative, this would be where I'd want to, so as you can imagine, there's a large volume of materials that I review and that go in front of me. So going through specific regs makes the specific detail, but the vast majority of these, my recollection of reviewing, either were already budgeted for, didn't have cost implications, were required by federal policy changes, were given legislative authorization from the state. I'm not comfortable representing, without having reviewed the specific regs where there's concerns, to make sure we just haven't had an oversight or had an error. And if we have, then as I've done before, then I'll acknowledge that and we can move forward and address that. But most of these, at least there's a big packet. There are like 10 open regs, if I remember right, potentially, that most of them are required by policy or were authorized by statute. And so it is my intention that we are complying. If we are not complying, then we can discuss that specifically, and I'd be happy to be accountable for that. With regard to the communication, this is one of those topics that we did discuss when we met. There are numerous committees of now jurisdiction that are reviewing the cabinet. And so we go before ours, we go before Family Services, Health Services, we come before MOAB, we have budget committees, we have, licensing and occupations now because of some of the things we do for environmental health. And so when I think we do rely in some way when we file things with LRC staff, that some of this gets routed additionally to other locations. So that's a central clearinghouse for support for all of these committees in different places. But again, 695 is new this year, right? And so there's probably opportunity for us to have staff collaborate and figure out, how these things are routed. It just gets tough. It's not, I could take this to the extreme, and there's 138 members of the legislature, and it could be we're individually notifying a third of the legislature at some point about all of these different things, at which point it might as well just go out to the legislature through LRC staff and everybody gets notified. So again, we do desire to have a good rapport, a good relationship. We do desire to comply to the best of our ability with these things. And we'd be happy to address the specifics if we could just know in advance what the specific concerns are, and then we'll come prepared to address those.
So, in the spirit of peace and love, peace and love, will you agree to participate in an informational meeting at the on these regs at our next Moab meeting?
Well, so you're asking for the next Moab meeting you'll put on the agenda, can we discuss whatever this process or whatever the regs are that you have? Can you just reframe that? Say that differently.
Yeah, I mean, can you agree to participate in an informational hearing on these regulations at our next meeting?
So to have an open discussion about the regs themselves?
Yes.
Yes. With that question now, my staff is listening. Let me just make sure that in an open comment period, that's the concern I'm sharing about commenting on the regs, is once they're in an open comment period, is the difficult. Now, can we answer questions about them? That gets difficult in a way because we're not to influence the process, I think, publicly once it's out there. But I hear your question, and can we just follow up with you offline about that? I have no problem coming, knowing what the questions are and being responsive to the questions. I just want to make sure I don't break the law or violate policy about talking about things in a certain period of time. And that's just a matter of what's the law say I'm supposed to do or not do.
Okay.
Well, I guess at a bare minimum, Dr. Syke, could you come at the next meeting just to talk about the process and your interpretation of 695 and those sorts of things?
Yeah,
I think bare minimum.
I think that could be a good discussion, actually, just so that we can
Yeah.
clarify what we're actually doing and see where there's differences of opinion. I think that, yes, we could definitely talk about 695. We could definitely talk about that other bill if that's of interest.
That'd be good. And if there is some language that needs to be modified to that House Bill 695 that we need to clarify in the next session, then we will address that.
Sure.
Just to make sure we're all clear.
And I think this is where a dialogue would be good, because I understand this is a huge program. I understand that you have a desire to provide appropriate oversight from the legislative branch. It's also a huge program that's incredibly complicated to run as far as the timelines and the things we have to do. And so I think an open dialogue about that would actually be very constructive. I'd be happy to do that. And be happy to talk about these other regs once the comment period closes. And we'd be happy to receive your comments if you want to. In an open comment period,
Okay.
you all as individuals or the legislature can comment. So
Okay, well,
just the way we do that part of it.
all right, at the bare minimum, you'll come back, we'll put you on the agenda to talk about the process, the procedures, and so forth, and you'll let us know basically on the actual substance of the regulations. You'll get back to us about
Yes.
if you can talk about that.
Yes, and then if you have any specific questions the committee would like us to address, please,
Okay.
if you could route those to us like you do the other items, we'd be happy to come prepared.
Okay. All right, thank you, Dr. Stack.
Okay.
Let's see. All righty.
Open comment.
Yes, we have public comment. We have 4 people on the list. You have 3 minutes each to address it. So if you don't mind, come on up. Mike Wynn. Yes, one at a time. Mike Lynn. Just make sure your microphone is green. You have the microphone close to your mouth.
Okay.
Just state your name and who you represent. And you have 3 minutes. Go ahead, sir.
Thank you for this opportunity to provide public comment. My name's Michael Wynn. I'm the Director of Community Programs for Grace Health. We are a federally qualified health center in southeastern Kentucky, serving 6 counties and over 40,000 patients a year. I wanted to take this opportunity to provide public comment to a recent testimony on Kentucky's Connector program. We've all heard the saying that the journey of 1,000 miles begins with the first step. When Kentuckians begin the 1,000-mile healthcare journey, Kentucky Connectors often represent that first step. Because of our aggressive, intentional community outreach programs, our 8 connectors at Grace Health have experienced 65,000 outreach contacts, last year and over 1,300 Medicaid and QHP new enrollments. Because Kentucky has made an investment in healthcare a priority, our connectors are qualified, certified, and empowered to educate, assist, and enroll. During that process, every new applicant will be asked if the information they are giving that connector is true to the best of their ability. They will also be warned during that application process of the penalties of Medicaid fraud. And then these connectors will spend hours uploading income documents into the system, as well as verification of citizenship or any verification that is needed for Kentucky residents. For the most part, the people who are sitting in our offices or in the offices of our connectors are people who are trapped in low-wage jobs but still have the dream of a family. Or it's a single mom or a single dad who's received some type of devastating diagnosis and is crying out for help. It's people recently out of work or recently out of rehab who haven't got their felonies expunged yet, and so they're struggling to find work. Our connectors are there, in the office, at the school, in the hospital, doing whatever they can to provide healthcare coverage resources and SNAP benefits to all Kentuckians who qualify. Therefore, it is my statement that through continued funding, our community health centers and our connector program will continue to find innovative ways to serve Kentuckians with the most effective, compassionate, and honest enrollment process in the nation. Thank you.
Thank you, Mr. Wynn. Appreciate your testimony. Next is Melissa Holland. Ms. Holland, just make sure the green light is on. The microphone's close to you. Go ahead and state your name and who you represent. And you have 3 minutes.
Thank you.
Yes,
My
ma'am.
name's Melissa Holland. I represent the Kentucky Council of Churches. We are, I represent 12 mainline Protestant churches and the Roman Catholic churches here in Kentucky. I want to call your attention, as you all, first off, I want to thank you all so much for what you do for the state of Kentucky in trying to make sure that our tax dollars and Medicaid is operating properly. I want to call to mind and have you keep in mind what our faith communities believe that we were taught by our Lord Jesus Christ when he's told us to care for the sick, to give food to the hungry and water to the thirsty and to house the homeless. We have so many in the state of Kentucky that cannot speak for themselves. When I hear the connectors talk, it is so important to make sure that all of our people have those connectors who can lead them through the processes that are so complicated in the Medicaid system. I personally was introduced to the Medicaid system when my mother, who died at the age of 98, my father had died. He died at the age of 78, and the investments they had were depleted by nursing home. My mother had Alzheimer's. It was depleted by nursing home care, and then we had to sell our house to finish that. If I hadn't been here to help, I don't know what would have happened to her. But she received the proper health care that she needed, and I oversaw everything within her health. I don't know how people who do not have family, there were 6 of us in my family, all of them were retired military except me. I was the only one living here in Lexington. So I took care of my mother and had the communication of having to go down and talk to the Medicaid office to make sure that she could get her Medicaid and swear that and give documentation that she only had $2,000 to her name. All of her Social Security went in to pay for her nursing home. And if it hadn't been for Medicare, I don't know what we would have done. So please, please, please remember that our Lord Jesus Christ said on the night before he died that love one another as I have loved you. I have been so pleased with our bishop, our governor, who frequently says, my faith tells me, he happens to be a member of one of our participating congregations, because he does speak from the faith and says that, remember, we are all family, we are all neighbors. It doesn't matter who we are or where we live. Here in Kentucky, we take care of one another. And so please, before you make any cuts to Medicaid, please remember how many people are really out there in grave need that have no one to speak up for them. You need to speak up for them. Thank you.
Thank you very much. Our next comment is from Kelly Talby. If I mispronounce that, please correct me. Just make sure the mic is close to you. The green light is on. State your name and who you represent, and you have the floor for 3 minutes.
Can you hear me? Is it on?
A little closer would be great.
How about now?
Perfect.
Okay.
Thank you very much.
Hi, my name is Kelly Talby. I'm the Director of Policy and Strategic Partnerships at Kentucky Voices for Health. At KVH, we believe that removing barriers to care is essential to improving health and preventing chronic disease. Sometimes the access barrier can be as simple and as solvable as providing transportation. As a coalition led by Consumer Voices, we talk to both Medicaid members and frontline community professionals statewide each year. When we ask about barriers to health care, transportation is always at the top of the list. When folks do know about NEMT, some common themes we hear are that customer service is poor with long wait times, delays, difficulty reaching brokers, and at times unsafe conditions. While anonymous reports are an option, in rural areas the fear of retaliation is real, and some of these negative interactions go unreported. Stories stick with you, though. A man with a broken leg who was mailed a bus ticket after his appointment. A mother experiencing homelessness who was told she would have to pay to bring her baby with her. A woman who was taken to her appointment and never picked back up. We should expect better from a benefit that costs millions each year with consistently low utilization rates. Improving NEMT will not prevent all no-shows from happening, but it will have an impact. More than 120,000 Kentuckians report having no vehicle in their home. Other families share one car to support all work, school, and other needs. These aren't new problems. NEMT has been a covered Medicaid benefit since the late 90s. It faced administrative issues from the jump. Hint, where is region number 7? It has not kept pace with technological advancements and simply does not work well for a lot of folks who need to use it. Regulatory inconsistencies for the administration of NEMT should be cleaned up to eliminate confusion for brokers. For daily rides to adult day programs or weekly rides for chemotherapy, NEMT may be working okay for you, but it's much less reliable for folks with primary care, behavioral health, or chronic care management needs. So let's make sure the next RFP gets the results we all want. Kentuckians deserve an official analysis of transportation delivery models that includes incentives tied to outcomes, allows more providers to participate and offer rides for patients, accommodations for caregivers, accessibility for people with disabilities, appropriate vehicles for wheelchairs, stretchers, and accommodations for children, good customer service, more responsive scheduling online. This board could take those findings and with innovation propel NEMT in Kentucky to a best practices intervention model of care. I want to thank the board for considering unpeeling the bureaucratic onion that is NEMT. Let's realign it so that it's an upstream intervention within our shared values and get people to their appointments, allow them to follow treatment protocol, and all while better spending our tax dollars. Thank you.
Thank you very much. I appreciate your comments. And the last comment we have is Gary Reckard. Reckard, is that?
I'll pass. Thank you.
You'll pass. All right. Well, thank you very much. I appreciate it. All right. I don't know if anybody has any last comments or thoughts. Ms. Subcamp, go ahead.
So I hate to pound on you. So last meeting, I had a question about the child waiver. We are concerned about the wait list that's automatically just baked into that. And I pointed out that it appeared that it was the priority was given to the children that are already in state custody and already at institutions. And they replied back that no, that was not the truth. So I backed off and thought, well, what in the world? So where did I pick all this up? So I went back and I pulled the application that CHFS made to CMS for the waiver, and it says priority enrollment is granted to children who are in the state's custody at risk of being unhoused or are currently unhoused or leaving an institution setting. And I went back through a few other things. One, there's 100 slots and it's 14 million, and we've never seen that math, so I don't know how to explain some of that. If the goal for this type of waiver is to keep people at their home, then why are you calling this a short-term stabilization program? If participants are in state custody, doesn't that effectively recycle the funding back into CHFS rather than giving it to the general public and the families that need this? I really felt like the child waiver took what the legislature intended to prevent people from getting to that upper acuity area, to prevent that, stop that from building, and instead you're dealing only with the higher acuity area levels of care. And I really feel like it's, one, you really are not providing a service to folks that need it and want to keep their children home and not have them taken away, or have to release that custody. And I just feel like when you all told me that priority enrollment is not, the priority is not to children in state custody, I was very confused.
Laura, I think since this is coming at the end of the meeting, and I like where you're going, if you could maybe submit a couple of questions to the chair, and then we can get it over to Medicaid for a response maybe by next meeting, and then we could share it with the rest of the committee members. Because I think it's valid, and I know I'm interested in hearing what the answers are too. So
thank you.
That is something great that you brought up, and I appreciate it.
I will do that.
Thank you, Ms. Sudkamp, and thank you, Senator Adams. If there's no other comments or questions, anybody else? Very good. All right, that our next time we will meet will be on October 22nd, I believe in 154 at 3 p.m. And thank you very much